Hello, everybody, and thank you for joining us today. Today, we will be hosting a webinar on motivational interviewing for smoking cessation. And this webinar is presented by the National Center for Health in Public Housing in collaboration with the National Healthcare for the Homeless Council. Before we begin, these are just a few housekeeping items to remind everyone about. All participants are muted upon entry. Please make sure that you engage in the chat if you have any questions or any comments that you would like to send to us. And just right now, we have enabled the chat so that you can type in any questions that you may have for us as well. Please also raise your hand if you would like your line to be unmuted. This meeting is being recorded, and the slides and the recording link will be sent to you all via email after today's session. This is just some background information about NCHPH. The mission of the National Center for Health in Public Housing is to strengthen the capacity of FQHCs that are funded by public housing primary care health centers and other health center grantees by providing a range of training and technical assistance. And with us today, again, my name is Fide Pineda Sandoval, and I am the TTA manager here at NCHPH. And I will be helping and facilitating today's webinar. With us, we also have Dr. Jose Leon, who is the Chief Medical Officer at NCHPH. And then we also have Elena Boyer, who is the Senior Director of Programs at the National Healthcare for the Homeless Council, and Frank Vitali, who is the National Director Pharmacy Partnership for Tobacco Cessation and Clinical Assistant Professor at Purdue University. And without further ado, I will pass it on to Frank Vitali, who will continue with today's presentation.
Thank you, Fide, and welcome. I am actually in Pittsburgh, not in Indiana where Purdue is. And it's a beautiful sunny day today. We're going to be getting into the 60s. So spring has definitely started here in town. So I have titled this a brief review of motivational interviewing because we only have about 45 minutes here to do this. And motivational interviewing, to be learned properly, is probably a 3 or 4 day course. So it's quite involved. There's a lot to it, but given that, there is a lot you can still do and a lot I can tell you in a few minutes. I've actually talked to many motivational interviewing trainers and asked them, what can I do in a few minutes? What are the important issues? What are the important highlights to get across to people who are taking a course like this and only have a few minutes? So I am going to touch upon some very doable, easy to incorporate things that you can put into practice as soon as you get off the training. So if you are interested in learning more about this, I will give you a couple references at the end. There are 2 books about motivational interviewing by the men who kind of invented this that you can read. They're very readable, very easy to understand, and will give you a lot of great information about the topic. All right, so let's get started here. All right, oops, sorry, went too fast. So our objectives today are very quickly just to help you understand the difference between what I'm calling a conventional patient encounter and motivational interviewing, give you some of the basic components of what a motivational interview would look like, and then we're just going to talk at the end about a sample. I'm going to give you a sample case, and we can just discuss some issues around what you think you would do with this patient now that you know a little bit about motivational interviewing. So what is motivational interviewing? Well, the technical definition is this: a skillful clinical style for eliciting from the patient their own good motivation for making behavior change. So first of all, this applies to all kinds of behavior change. The difference between what we and anybody on this call, any healthcare professional pretty much does, and motivational interviewing is this. Generally speaking, we are telling the patient what to do. this is the medication that you take, this is the procedure that you need, this is what I would like you to do, et cetera, et cetera, et cetera. So we are, in effect, commanding or giving information and telling them you have to do blah, blah, blah. Motivational interviewing is, in many respects, the opposite. It is us providing such powerful information and asking such provocative questions that the patient tells us they want to change rather than us telling them they have to change. Okay? So think about that for a moment. We are asking such provocative questions and providing such powerful information that the patient tells us they want to change rather than us telling them they have to change. The rationale behind this, and if you think about this with yourself, we only tend to make changes that last and are permanent if the words come out of our own mouth rather than having somebody else tell us that we have to do it. Yes, we do make changes for other people, but I would say in general, most of those changes don't last. They're done short term, and then we kind of find a way to get back to what we were doing. So with motivational interviewing, we are helping the person come up with their own reasons to make the change, which then are much stronger and last much longer. So it's just a shift in your perspective. And as I said, you can do this in any kind of interaction with any patient about what needs to be done, in particularly for them to change a particular behavior. Oops. Okay, I'm getting a little too fast here on the, there we go. All right, sometimes it takes a minute for this, the slides to kick in. So in other words, we are guiding the patient, and that's a key word, to tell us that they want to change rather than telling us telling them they have to change. So the words, again, are coming out of their own mouth. Now, in this technique, you are avoiding all of the finger wagging and the nagging and the guilt, because if you do this, think about it, especially if you are talking to somebody about quitting smoking and you say to them, you better quit smoking or you're going to die. Number one, they're going to tell you, well, I got to die of something, right? So that argument really doesn't work very well. But in many respects, what you become when you do that is their mother. You become their mother chastising the naughty child for doing something wrong. And that doesn't work on two fronts. Number one, none of us want to become our patients' mothers. You know, it's not very comfortable for us. And number two, what does the patient do? The patient does what we did when we were kids. We generally resist and we don't want to do it. We resent being told what to do. So this technique avoids all of that. And that leads me to really emphasizing here, I've done this for 36 years. I've worked with thousands and thousands of patients, and I've never, ever told any of them that they have to stop smoking, because that's not up to me to tell them that. What I do, though, is provide them and help them find a motivation so that, again, they're going to want to quit rather than me telling them they have to quit. Even if it's somebody that has a very serious illness or has to have is being told to quit because they have to have surgery, I always get it around to having them tell me they want to quit. Because again, that is much more powerful than me hollering at them or chastising them or making them feel guilty. So the benefits to this are you don't have those frustrating conversations, and you never then begin to look at the patient as non-compliant. And what this does is it establishes a real collaboration between you and the patient. Again, think of the word guide. So how do you do this? How can you incorporate this into your work with any of your patients? Well, first of all, begin by accepting the fact that ambivalence exists. And we'll talk about that in a little bit later. Any change that any of us have ever made, I doubt that most of us are 100% behind it right from the beginning. We are a bit ambivalent. So there's no problem with ambivalence. The issue is getting stuck there. Number two, you have to understand that change, no matter what it is a learning process. And that relapse is a natural part of this process. So that doesn't mean you're a failure. And I don't say that in the sense that I want you to encourage people to relapse, but it happens. So you have to deal with it and deal with it in a productive way. I always look at this like learning how to ride a bicycle. We've all, when we get on that bicycle the first time, have fallen off. But 99% of us just don't say, oh, I can't do this. We figure out what we did right, what we did wrong, and we get back on the bike. So that's all this is. It's a learning process. And then, as I said, we want these words to come out of the patient's own mouth. So that's what change talk is. And I will give you some pointers on how to elicit that. Again, we want to not only help them find their own motivation for change, but to view that change as more enticing, as more interesting, as more powerful than what is occurring right now. And importantly, we have to help them believe they can change. Especially with our people who smoke, I think many of them have half-heartedly tried to quit over the years, many, many times. And what that has done is cemented in their brain that they can't do it. So part of what we're doing here is helping them understand that they can. Again, from the perspective that change is more likely to occur when the idea comes from the individual, not from you. So why don't people change? What's in it for them to maintain the old behavior? Well, basically, it has value. There's a benefit to it. I know that may sound odd, but if you really start to talk with people who smoke, they will tell you that they're doing it because they think it's doing something for them that they can't do on their own. So that basically makes them afraid to change and they don't want to change, and they are thinking that they can't change. So part of what we're doing here is help them understand that the new, whatever that is, so in our case, being a non-smoker, is more valuable and is more important in their life than continuing to smoke. That involves making them uncomfortable with the fact that they are smoking and making them comfortable with the prospect of changing by allowing them to understand that they do have the skills and the knowledge to be able to do it. Now, it's important to understand that change, as I've said before, is a learning process, and that's the key word. It's a process that occurs over time. It's not a discrete one-time event. So in your working with patients, it's important to understand that quitting smoking just doesn't happen instantaneously after talking to somebody one time. Yes, I do know there are people that have quit. When something happens, they get a diagnosis of a heart attack or cancer or something, and it appears that they have just quit, boom, instantaneously. But I contend that they've been thinking about it for a long time, and there's a lot going on in their minds that we're not really aware of. So for you, it's important to understand that change falls into this model that really applies to any kind of change, but really applies beautifully to quitting smoking. So what are we looking at here? Well, first of all, the person is not even thinking about quitting. They're not even thinking about making the change. They're perfectly happy. And then something happens and they begin to consider it. It's maybe I will, maybe I won't. And that's probably the majority of people that you are going to encounter. And the reason they haven't moved on to actually quitting is they don't have a clear-cut motivation to do so. So our role with people who are contemplating quitting is to help them find that motivation. So that's what all this is going to be about, for the rest of my talk. Hopefully then that spurs them into action. And then, of course, we want them to maintain that change. So there are many things we as clinicians can do to help that, help them maintain that and stay quit permanently. But there are slips, which is an occasional cigarette here and there, and then full-blown relapse. So when I do these trainings and we have a full-day training, then I go into a lot of detail about what you can do in each one of those stages. Today, we're going to focus mainly on that contemplation stage. So we, again, want the patient to say the words, I want to change or I want to quit. So we want to create that change talk. So how do we do that? 5 key elements here. First of all, you ask permission. You use open-ended questions. You really listen to what the person has to say, and then give you some phrases you can use that lets the patient know you are listening. You want to summarize, and then, as I said, roll with ambivalence. So what do you do with the ambivalent person? So I'm going to go over these in more detail. There's lots of sample language on here. I'm not going to read these slides. I'm not going to read all these suggested sentences. What I'd like you to do afterwards, you're getting a copy of these slides, is look it over yourself and then put the ideas into your own words, because it'll be more genuine than just simply repeating what I'm suggesting. So first of all, and I think you'll understand this from anything that you've ever done, is you want to approach this from a perspective of asking permission, of respecting the person. So don't just launch into it. Ask, do you mind if we talk about this today? And hopefully, most people, unless they're really, really upset about something, will talk about it at least with you. I would, in most cases. So this is a way to ask permission. So you go from there, the person says yes. Then, and this is the one thing that I think you can do very quickly, and as soon as you get off this call, is start to incorporate open-ended questions when you are discussing this subject with your patients. So don't say to somebody, don't you know smoking's bad for you? Because the person's going to say yes, and that's it. This is not a conversation. So what you're trying to do here is to create a dialogue with the patient so that you can understand what their barriers are, so why they haven't done this yet, and what their possible motivations might be. So the best way to do that is to ask open-ended questions. The definition of that is questions that do not invite short or one-word answers. Now, what word or words should you start these questions with in order to generate a conversation? So just think for 1 minute, what are the 2 most powerful words you can use to create open-ended questions? Okay, they are what and how. This almost forces the person to give you a detailed answer. It's very difficult to answer a question that begins with what or how with 1 word, if you think about it. So this kind of starts to create dialogue. I stay away from the word why as much as I can, because why in our culture for most of us implies a judgment, and it has a negative connotation. You can ask the same question that normally you would ask beginning with why with the word what or how, and again, it doesn't come across as being so judgmental. So what or how questions will really help you create dialogue with your patients. And you can use that all the time with all kinds of different things. Here are some samples. Again, I'm not going to read through them. This gives you an idea of what you can ask. Now, if somebody is still reluctant after you've had this discussion, I think this is a very powerful question. What would have to happen to you for you to consider, in this case, quitting smoking? Now, if someone says to you, well, I have to get lung cancer, then okay, now you know what their barrier is, and you can then educate them on what actually happens when someone gets lung cancer. What are the chances of it being cured, et cetera, et cetera. I think from my experience, again, with all these patients I've worked with, is everybody, or not everybody, many people in this country think there is a pill that you can take that'll cure everything. And so they don't realize that, especially with smoking-related illnesses, that the best cure is prevention. You want to prevent yourself from getting these illnesses. So again, asking this type of question opens up a dialogue And you can find out a lot of information from an individual by asking what or how. Now, a way to do this, I'm going to give you two rulers here, importance and confidence. So you've probably seen this before, but it really applies very well here. How important would you say it is for you to quit? And this is just using that 1 to 10 scale, and saying, having them tell you. Now, what I do here is if somebody says, well, I'm a 4, instead of saying, well, why aren't you a 1 or a 2, is to say to them, well, you know what, in our conversation, it sounds to me like you're a 6 or a 7. So you're kind of nudging them a little bit by encouraging them to think about this and give it a more importance than they actually are. And then the confidence ruler, same thing. How, if you decided to stop tobacco use now, how confident are you that you could do it? Now, you're probably going to get most people tell you they're only a 1 or a 2 or a 3. So I have a really good, powerful way to increase that. And here's what I do. Ask this question. What accomplishment in your life are you the most proud of? Now, the person may say, well, I climbed a mountain, I raised 3 kids, I paid for my own way through college. Whatever they say, your next comment is, if you can do that, you can quit smoking. Now, I know this isn't a miracle statement, and it automatically doesn't mean that a person will change their mind, but I have seen people just go through some dramatic changes in their own thinking when I've said that to them. Because by and large, whatever their accomplishment was is much more difficult to have done than quitting smoking. So this is a really cool way to do this in a minute or two. What accomplishment are you most proud of? And whatever they say, you say, if you can do that, you can quit smoking. Now, you can also look at what their values are, what their goals in life. This is especially good if you know a patient, and especially good if a patient is religious, because in almost every religion on this planet, we teach that the body is a temple. And so if you're smoking, you are destroying the temple. So how does that fit into your goals? How does that fit into your lifestyle? You can get a lot of really good information, and again, learn a lot of what the barriers are for an individual by asking these types of questions. You always want to get an in-depth understanding of their situation. So the questions then become more statements like, tell me more about this. Many people have this like vague, especially when they relapse, they'll tell you, well, it just happened. You know, and it's like some alien entity beamed the cigarette into their mouth and lit it, and they're smoking and they don't even know how it happened. So what you want to really do is to get the person to think and provide detail for you. So this is just a way of asking that and getting more information. I like this way of questioning people. What do you imagine your life to be like in the next few years if you don't quit? Or what would it be like if you did quit? So this is going to either extreme. Again, this gets the people thinking about the situation. So those are all sample questions in the what and how, the open-ended questions. It gives you a bunch of different ways to go about that. Again, I want you to look at this afterwards, see what works for you, what feels comfortable for you, and what you think you can fit into your discussions. Now, once you've done that, you really, or as you're doing that, you really want to listen to what the person is saying back to you, and then reflect that to them. So here are 2 examples. Somebody may say, well, I want to quit, but it's really, really scary. So you can just reflect that right back. That lets the person know you're paying attention. And then you want to summarize everything. So at the end of every session, you kind of give them feedback on what you just discussed. And then at the same time, I always like to then give them homework, either something to do or even just something to think about between now and the next session. So this is a way to do that. Now, if somebody again tells you that they're not sure, that they're ambivalent about it, they want to, but they really don't want to, then here's some things you can do to help with that. Again, this isn't bad. You don't have to worry about this if a patient is ambivalent, because I would tell you that almost everybody you encounter is going to be that way. But the issue here is helping them move beyond that. So you don't want them to get stuck there. So these are some samples, words, some sentences that you can use with that. But if you find that somebody is really kind of stuck there, they really seem to not be able to move past it, then I have this decisional balance sheet. And again, I know you've seen this before, you've used this in other situations. You're basically just taking a piece of paper. On one side, you're putting smoking, other side, not smoking. And then you're looking at the pros and cons of each. Now, again, you may think it's odd that I'm saying that there are benefits or that there are pros to smoking. Well, that's exactly why the person is continuing to do this, because they do think they're benefiting from it, that there are pros to it. So we want to find out what those are so we can work with changing that belief and showing them that there really isn't any good reason to continue. And interestingly enough, what I have discovered is that writing all this down actually makes it more clear than just talking about it, than just saying it. I find that if you're talking to somebody, they think they can come up with all these really good reasons to continue to smoke and don't have any good reasons for stopping. But when they actually write it down, they are finding that it's very difficult to come up with a lot of good reasons to continue. And indeed, there are many good reasons to stop. So this is a great technique. This is a great way to help individuals clarify their reasoning and their rationale. So this whole thing then is designed to help you help the patient find a clear, strong internal reason for quitting, losing weight, change, whatever it is you're doing with the patient. Now, what could those be? Well, you really want to focus, since we're all healthcare professionals, I would assume on this call, somehow or another linking this with their presenting illness in a way that is personal or is real to them. So again, just telling somebody you need to quit smoking doesn't really mean anything, because they know that. Every smoker knows that they shouldn't be doing it. And especially if you're someone who has a diagnosis of COPD or heart problems or cancer, you really want to look at how smoking is impacting that illness. So it's impacting it in one of three ways. We know for sure that if someone is smoking, it's either causing the illness that you are treating, exacerbating the symptoms of those illnesses, or we know that smokers have impaired immune response. So they get sick more often than people who don't smoke, and it takes them a lot longer to recover than someone who doesn't smoke. They've even done studies with stuff like back surgery. I remember reading this many years ago. People who have back surgery and who are smoking are in the hospital on average 2 weeks longer and take 2 weeks longer to recover than people who don't smoke. So from a personal perspective, it's impacting it, but from our societal perspective, it's actually putting more burden on the healthcare system, and it's costing a lot more. So we know that people who smoke get colds more often. I mean, I can just go through the whole list. You know, there's all kinds of issues with your oral teeth, you know, dentistry, even with behavioral health. So we know very clearly that individuals who don't smoke or who quit tend to stay sober longer and have less exacerbations of many different types of mental health. I did some trainings on that with NCHPH, It's on their website. If you want to look at that, you can get some more information about that. So the point here is that it's affecting the person negatively in some way, shape, or form. So really make that link. And then again, don't talk about death, because everybody knows, and I've had people, and I've seen this, and when a clinician says, you better quit smoking or you're going to die, the individual says, well, you got to die something, so I might as well be doing something I enjoy. So that's not the way to go. And besides, most people who smoke have this very bizarre idea that they're just going to instantly die from whatever the smoking related illness is. Like, they're just going to collapse like this. The angels will take them to heaven and bing, bang, boom, they're done. Well, the reality is that, as you know, that most smoking related illnesses take a long time to get you to the point where you're dying. My grandfather had a stroke because of his smoking, and he laid in bed for 13 years. So, that's a good way to motivate people is, tell them that somebody like that, and then just say, what would it be like if you had to lay in bed for the next 13 years? Or I've worked with a girl who was 26 and she had emphysema already, and she had to have oxygen. So how would you feel if you had to take an oxygen tank around with you all over the place? So that's more motivating than telling someone that they're going to die. Money, it's very expensive now to smoke. I know here in Pittsburgh, at the various stores that are in my neighborhood, they're mostly $10, $11, $12 a pack. I was just in Manhattan 2 weekends ago. It's $15, $18 a pack there. In Australia, when I was there about 8 or 9 years ago, it was $20 a pack. So most people are spending $3,000, $4,000, $5,000 a year on cigarettes, and what are they getting for it? So it's really helpful to add that all up for the patient and help them understand how much money they're spending, and then ask them, what else could you use that money for? Family, society is changing, so there are many different motivations there. And then just really quickly, before we move on to our case, anything can be a motivation for quitting. I had a woman who ran into my office. So this woman was in her 70s and ran in one day, just frantic, Frank, I have to quit smoking. I have to quit smoking right now. I said, okay, I'd be happy to work with you. No, you don't understand. I have to do it right now. And I said, okay, just take a deep breath, calm down. And before I really got into it, I said, well, I don't understand. She was in a research project that I was doing. I said, we've been working together for years. Why right now? What's so important right now that you have to quit? And before she said anything, I said, oh, I bet you were across the street at your doctor's office and you got some bad news about your health. And she said, no, 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 no. This has nothing to do with me. It's poor little Fifi. Now, who is Fifi? Well, Fifi was her poodle, was her dog. Now, some of you may be kind of laughing or smiling, and I kind of did that internally. Obviously, I did not do that so that she could see me. What I did do, what she did see or what she heard from me is, wow, that's an excellent reason to quit, and I will do everything I can to make a healthy home for Fifi. Now, by the way, that is true. Small animals, dogs, cats, and birds can get lung cancer. This dog had COPD, believe it or not, because of being exposed to secondhand smoke. So it is real. It does happen. And she was not really that concerned about her own health, so I didn't go there. I just focused on Fifi, and we worked together, and guess what? She quit. So again, the goal of all of this is to help that individual find a very personal reason for quitting. The other thing you can do in addition to all of these questions and information is just to be supportive. I have found that in many cases, many, many patients don't have anybody that's really supporting them in their quit. In fact, many of their friends are people who smoke, family members smoke, so they don't want the patient to quit because then it makes them look bad, forces them to think about it. So it's really important that we act as that support for the individual. All right, so we have about 10, 15 minutes here. I would like you to come off mute or use the chat And let's talk about a particular case. So I'm just going to go through the particulars here, and I'm going to ask you some questions pertaining to Alyssa. And let's see what you can come up with in terms of whether or not the what you would do to help Alyssa get to the point of quitting or wanting to quit. All right, so I can't see the chat yet, so let me see here. Oh, there it is. All right. Perfect. All right, so, oops, let me go back here. All right, so sorry about that. All right, Alyssa is 30 years old. She's a music teacher and she plays trombone herself. She's ambivalent about quitting, but she has cut down to about 10 cigarettes a day. She has 3 kids. And what's interesting is that she did quit every time she had a child. She's currently, though, smoking, and she's married to a smoker. His name is Sean. Now, her history and why you're discussing this is she just has been told that she's in the very early stages of COPD. She's on, the only other medication that she's taking is an oral contraceptive. She doesn't want to have any more children, but she does have eczema and no other medical issues. So my first question is, okay, she's cut down. Is that a good thing? Is that a bad thing? Should we be happy about that? Should we be settled with that? So if a patient tells you that they've cut down from what they were smoking in the past, how should we react to that? So again, type something in the chat, or if you want to come off mute, raise your hand and Fide will take you off of mute. Okay, Dawn says, good, congratulations on success so far. Okay, great. Go ahead.
This is Joseph here. What I would also say is, okay, I see that you, and I don't know if you were just saying this because I was just trying to unmute myself, but I would say I see that you actually cut back. What encouraged you to cut back? And kind of use that as a starting point to
Excellent.
start the conversation.
Right. And then everybody else has said that they would congratulate her, same as what you're saying. So Joseph, would we be happy with that? Would we be satisfied with that?
I would be happy with that. Absolutely. You cut back from a pack a day to 10 cigarettes a day. Yeah, let's celebrate that.
Would we stop there?
No.
Okay.
We have we got 10 more cigarettes to go.
Great. Right. That's the point I want to make here with everybody is, yes, that is good. Yes, we are happy that she's done that. But with smoking, we don't know which cigarette is going to create more problems or create the problem with a person's health. So it's not good enough. So I don't want us to get to the point of thinking that cutting back is okay. There is no safe level of smoking, period. Okay. The only safe level is 0. So yeah, you're absolutely right. We would congratulate her and then start working on, yeah, you know what? I'm really happy that you've got down to 10, but there is no safe level of smoking. So let's work together to get you completely quit. So what would you talk about with her to help her get to the point of quitting completely? What topics, what kind of questions would you ask her? So look at her history here. Very good. Elena said, I might start with how does smoking affect your ability to play the trombone? Exactly right. That's why I put that in there. She has the beginnings of COPD. So you really want to connect this. I played trombone in high school, and I know you need a lot of wind and a lot of power. So that's a very good question. Instead of telling her, oh, this is going to prevent you from playing the trombone, or you're going to be getting winded more often, ask her the question, how do you think this is going to affect your playing the trombone? And I'll bet probably it's already started to affect her. All right, so number one. Number two, what else might be a motivator here? Right, so Dawn said effect on her family. So how is your smoking affecting your family? Now, what if she says, well, I don't smoke in the house. I never smoke around my kids. I go outside on the porch all the time. So in her mind, that solved the problem. Is her smoking on the porch not affecting her children? Any thoughts on that from anybody? Yeah, so again, time and money. So her smoking is taking away from her being active with the kids, but it's costing a lot of money. So, I wouldn't say that it is maybe make or break in most cases, but an extra $3,000 or $4,000 with 3 kids can really go a long way to taking them on a vacation or something like that. So again, even if she's smoking on the porch, it's affecting her health, which is then affecting the kids, but it's also affecting her pocketbook. And what else? What is she showing her kids by smoking? Right. So ask her if she knows about secondhand smoke. Absolutely right. But in many cases, many people start smoking because they see their parents smoking. So she's setting an example for her kids that it's okay, that it's a normal thing to do. And as you know, kids are more likely to do what they see rather than what you tell them. So if she may be telling them that they shouldn't be smoking, but she's doing it, then they're more likely to want to smoke when they get older. Now, it's not a guarantee. Both of my parents smoked, and that did not prompt me or my brother or sister to smoke, but it does increase the chances that the child may smoke. All right, so if we look at her health history here, what is the connection between COPD and smoking? Does anybody know that? All right, well, COPD is one of the few things that is directly caused by smoking. And we know that all the oral inhalers do is treat the symptoms. Really, the only way to reverse COPD is to quit smoking. So that's a piece of information. So remember I told you providing powerful information to the individual. She's at an early stage, and let's just for the sake of argument say that it's early enough that it can be reduced, and in many cases it can. I worked on a large study years ago where we saw that once you quit, many people go back to normal lung function. So that's how you want to educate her, not from if you continue to do this, you're going to not be able to breathe and you're going to be on oxygen, but saying actual facts. You've only lost 3% of your lung capacity or whatever it would be. And we know that if you stop now, it's very likely that you will regain the lung capacity you lost because of smoking. Now, what does oral contraceptive have to do? Okay, good. Dwight got that right before as I was asking. So I threw that in there. If you've been on some of the other trainings I've done for this series, you've gotten that, or you may already know that you are at risk for all kinds of cardiac issues if you're using oral contraceptives and smoke, especially if you are over 35 and smoke more than 15 cigarettes a day. So the use of oral contraceptives increases your risk for cardiac issues and thrombosis, all that kind of stuff. Smoking increases that risk. So doing this in combination really does significantly increase your risk. And, you know, I train a lot of pharmacists. We've really worked on having them explain this to patients and really asking all women who are on oral contraceptives if they are smoking, because if they are, then they should switch to something else, another form of contraception, or if they want to stay on that, then they should quit smoking. So here's another reason to look at a person's complete health history. Now, somebody just brought up, and I really like that. So that was the next thing I was going to bring up. So she quit while she was pregnant with each child. So how would you want to explore that? What would you want to ask her? Okay, Dawn has some excellent questions there. How did she quit during each pregnancy? What was her motivation? Yep. So I have several people asking those types of questions. How did she feel? What were her barriers? How did she do it? Who was supportive? All those are great questions. It's excellent, excellent questions. One of the other things I would ask is what occurred that you went back to smoking? So let's understand her thinking by looking at what brought her back to smoking. And that in many cases, then, she did this 3 times. So obviously she can do it. And she did it for probably close to a year for each time. So, at least 9 months, or, when she found out that she was pregnant. So she has the capability of it. So what's going on? What went on each time that she was motivated to quit? What was the process? How did it work? How did you feel? And then what brought you back to smoking? What was it that prompted you to start again? Those relapses, and I'll call this a relapse, even though it was probably deliberate, those are gold mines of information for you right now. They really tell you a lot about what is going on in the person's mind and how they're thinking. So mind that, as I say, find that and use that information to help set up a motivation for now. All right, now she's married to Sean, who smokes. So what's that all about? How do you deal with that? Let's ask that question. How do you deal with the fact that the husband smokes? What would you suggest that she do? Any thoughts about that from anybody? All right, some of you may think that this is really difficult and that you may not be able to quit if you have a spouse that smokes, but it works. I've seen it many, many, many times. What you want to do is negotiate with the spouse and have that person only smoke in a specific place where you aren't seeing them. So you would ask them maybe, and I usually would suggest that they go outside. Number 2, they hide their cigarettes so that you can't find them. And number 3, they have one ashtray and they clean that out after they use it. So you really negotiate with the person, don't demand, but you negotiate with them about where, when, how, all that kind of stuff. And I always say that after that you've been quit for a month or so, and this person's gone along with you, that you then take that person out to dinner or do something special for them to thank them for their cooperation. And you know what I've seen happen is if the one spouse quits, the other one sees that it could be done, then that really then in many cases prompts them to want to quit too. So quitting with another smoker in the house with another person who smokes can happen. It's not necessarily impossible. All right, so this person, if you took any of the classes that I had with the medications, could use almost any of the medications. I would stay away from the patch because this person has eczema, and obviously there's would be issues with their skin. But other than that, they can probably use any of the medications, and they might even be able to use the patch if the eczema is only in very specific issues. Then they can put it on places where the individual, where there is no eczema. All right, somebody said that we're going to wrap up here because we have to end. I have a client that doesn't smoke during the week, but once the weekend arrives, from Friday night to Sunday, he smokes a full pack. Yeah, that really speaks to behavior and habit, and probably going out and drinking and connecting the two things. That isn't necessarily a physical addiction, but they might need to use a medication just on the weekends. Yeah, there's all kinds of varieties here. There's all kinds of variations. So you really do need to work with an individual, find out exactly what their pattern is, and then create a treatment plan to deal with that. All right, so we're going to wrap it up here. Just remember here that you can't make anybody change. The more you push, the more they're going to resist. So what we want to do here is, again, provide them with such powerful information and ask such provocative questions that they tell us they want to change rather than us telling them they have to change. This is my contact information if you need any more information from me. And then I want to end here with these two references. If you want to really get into motivational interviewing, there are courses around the country. There's stuff online. But these two books written by Milner and Rolnick, who are the guys that kind of invented this, are very good references, especially the second one that will tell you how to use this in a healthcare setting. So again, I hope this whetted your appetite and get you interested in doing this with your patients. Again, the simple thing to do is start to ask open-ended questions. And like, as I said, with what or how, you can do that right away. And FIDE will send you a link that has all of the slides on it. I guess Joseph has lost the pictures. So the book is Motivational Interviewing in Healthcare. And the author is William Miller, M-I-L-L-E-R. All right, thank you so much. We are going to end now because our NCHPH people have another webinar to get to. So if you have any questions, you have my email. You can send that out to me, and I'd be happy to help you.
All right, thank you. Thank you, everyone, and thank you for joining us today. Thank you, Frank. Thank you, Elena and Dr. Neil. We just want to remind everyone to please complete your post-evaluation survey on logging out from the Zoom meeting. We really appreciate your feedback. And here is our contact information. If you would like to reach out to us with any additional questions, we can always refer the questions to our speakers. Thank you so much and have a good rest of your day.
Thanks. Bye-bye.